Hey everyone, and welcome to the Deep Dive.
Hello.
Today we're tackling a topic that's super important, especially for, those of you heading into healthcare. We've got some really solid material here, mainly a big PDF document and also a text file, all focused on anxiety and related disorders.
That's right. And our goal today, well, is pretty specific. We want to walk you, especially you UTMB students, through this stuff to help you get ready for exam one.
Yeah, exactly.
We're going to try and pull out the key knowledge, the really important insights. We're talking definitions, symptoms, causes, nursing stuff, treatments. It's all in there.
Think of this as maybe your study guide booster. We're going to unpack these sources together, try to make it all clearer.
Okay, let's dive in. First things first, we need to get the core concepts straight. The sources are pretty clear about differentiating stress, anxiety, and fear.
Yeah.
It's crucial you understand these distinctions.
Okay, let's unpack this then. So, stress. The sources define that as the external thing, right? The pressure that's put on you.
Right, the trigger from outside.
Yeah.
And anxiety, well, that's different. It's the internal response. It's described as that subjective emotional feeling you get because of the stressor.
An emotional response, like anticipating something bad, fear, or danger.
Exactly. And interestingly, the material points out that often you don't even know what the specific danger is, or you can't quite put your finger on it.
So stress is external, anxiety is the internal feeling, often vague. And you mentioned it's described as both a symptom and a disorder.
Yeah, that's a really key point. It could be a sign of something else, or it can be the primary problem itself.
Yeah.
Now, where does fear fit in?
Okay.
The sources make a distinction here. Fear is more of a cognitive process, they say. Anxiety is emotional, fear is cognitive.
Cognitive how?
Well, fear is that intense emotional response, but it's triggered by detecting a threat that's right there, imminent, and you know what it is.
Got it. So stress, outside trigger, leads to anxiety, inside feeling, maybe vague source, while fear is that immediate reaction to a known present danger. That feels really practical for, assessment.
It really is. And, the sources remind us a certain amount of anxiety is normal, even necessary for survival. It gets us going.
But then there's the question, how much is too much?
Exactly. And that's where pathological anxiety comes in. The definition they give is when the anxiety is way out of proportion to whatever's causing it. Or, and this is critical, when it starts messing up your life.
Interfering with social stuff, work, school.
Right. They use that example of Mrs. K, the woman who saw a bad car accident. Her reaction afterwards, refusing to drive at all, quitting her job. That shows how anxiety becomes pathological. It completely disrupted her functioning long after the immediate danger was gone.
Yeah, that case really drives it home. Okay, so if that's pathological anxiety, where does it come from? The sources talk about a bunch of factors, right? Like a model of multiple causation.
Exactly. It's rarely just one single thing.
Yeah.
It's usually this complex mix. If we start with the biological factors, genetics is definitely in the picture.
How strong is the genetic link?
The sources suggest a moderate vulnerability. They mention heritability around 30 to 50%. Specific gene variations are linked to anxiety and OCD. But it's not just the genes themselves.
It's how they interact with life, your environment.
Precisely. Gene-environment interactions are key. Plus, there seems to be a familial predisposition it tends to run in families.
Okay, genetics. What else biologically? Neurobiology, brain stuff.
Yeah, neurobiology and neuroanatomy. This part's pretty detailed in the sources, but the main idea is that there are disturbances, like imbalances in certain brain areas and with specific neurotransmitters.
Which areas?
Well, they list quite a few. The amygdala, that's big for fear and panic. The hippocampus, linking memory and fear. The locus coeruleus, involved in arousal. The frontal cortex, for how we think about things. They even mention specific circuits, like involving the temporal lobes in panic disorder, or the prefrontal cortex storing fear memories and phobias.
And the neurotransmitters are the messengers,
Oh.
right? Like serotonin, norepinephrine.
Exactly. Serotonin, norepinephrine, GABA, and glutamate are the main ones highlighted. Understanding these helps us see why certain treatments work.
How so?
Well, the material suggests serotonin might be low in anxiety. That's why SSRIs often help. They boost serotonin. Norepinephrine is linked to arousal. Maybe it's too high. GABA is like the brain's brake pedal. It's inhibitory, and it might be decreased.
Which is why benzodiazepines work. They boost GABA.
You got it. They enhance GABA's effect. And glutamate, the main excitatory one, is also implicated, especially
Wow.
they think in OCD.
Makes sense. Knowing the pathways helps explain the meds. What about biochemical factors? They mention blood lactate.
Yeah, things like abnormal levels of blood lactate and panic disorder or
Mhm.
sensitivity to CO2. It also notes that simple things like deep breathing exercises can actually impact neurotransmitter levels, like boosting GABA in the thalamus. Fascinating stuff.
Okay, so that's the biological side. What about the psychological factors?
The sources covered a few different theories here. Psychodynamic theory, stemming from Freud, talks about internal conflicts, like the ego struggling to balance the id, desires, and superego rules.
Mm.
If the ego can't manage, it uses defense mechanisms, and if those are maladaptive, anxiety pops up. They mentioned underdeveloped egos in OCD here.
Okay. What else?
Cognitive theory. This one feels maybe more practical day to day. It focuses on those faulty, distorted thinking patterns, negative self-talk, irrational beliefs, blowing things out of proportion.
So the thinking itself keeps the anxiety going.
Exactly. The idea is that anxiety is maintained by these dysfunctional ways of appraising situations. It's a really key concept for treatments like CBT.
Right. Then there's learning theory, like conditioning.
Yeah. Classic conditioning, you pair something neutral with something scary, and suddenly the neutral thing becomes scary,
Yeah.
like Pavlov's dogs. But for fear.
And avoidance plays a role.
Huge role. Avoiding the thing you fear or doing rituals like an OCD provides temporary relief. That relief acts as a powerful reward, so you keep doing it, reinforcing the cycle. Phobias can also be learned just by watching someone else modeling or from trauma.
They also mention locus of control, internal versus external.
Right. Do you feel like you're in control, internal, or are things happening to you, external? The sources suggest this might influence how people experience or label anxiety. Someone with an external locus might feel more powerless or blame outside factors.
And environmental factors seem pretty obvious. Stressful life events, pressure.
Yep. But it also includes things like early trauma interacting with those genetic vulnerabilities we talked about. Even things like being punished harshly as a kid or having accidents can potentially set the stage for phobias later on.
Lastly, temperament, our basic disposition.
Yeah, some fears are just part of growing up: loud noises, strangers, the dark. But the sources say if these normal developmental fears get strongly reinforced later, maybe through a bad experience, they can intensify into a phobia, like a kid afraid of dogs who then gets bitten as an adult.
Wow. Okay, so it's definitely a mix of biology, psychology, environment, a whole web. So let's look at how this pathological anxiety actually shows up, the specific disorders. What about panic attacks?
Yeah, the sources describe these vividly: sudden, overwhelming terror, feeling like you're doomed. Intense physical symptoms hit you like a ton of bricks.
Like what? What are the key ones?
Sweating, trembling, shortness of breath, feeling like you're choking, chest pain, nausea, dizziness, chills or hot flashes, numbness or tingling.
Yeah.
That weird feeling of unreality, derealization, or depersonalization.
And that awful fear of losing control or dying.
Exactly. The good news is they usually peak fast and don't last for hours, usually just minutes.
Yeah, okay. And panic disorder is when you have these attacks repeatedly.
Right, but the key word is unexpected. Recurrent, unexpected panic attacks. Plus, you develop this persistent worry about having more attacks, or you change your behavior significantly to avoid them.
So it's the fear of the fear, almost.
Very much so. It might happen with or without agoraphobia, which we'll get to. It's important to differentiate this from just being in a crisis. Onset is often late 20s. Risk factors mentioned include genetics, trauma, even smoking or asthma.
Then there's generalized anxiety disorder, GAD. That sounds less like sudden attacks and more constant.
Exactly. Chronic, excessive worry that feels unrealistic and pervasive. It's not just situation specific. It's there more days than not for at least 6 months.
And it comes with physical symptoms, too.
Yeah. Associated with 3 or more things like feeling restless or keyed up, easily fatigued, trouble concentrating mind, going blank, irritability, muscle tension, sleep problems. This really gets in the way of life.
So people with GAD might avoid things, put stuff off.
Definitely. Procrastination is mentioned as a classic defense. They might also constantly seek reassurance. It tends to start after age 20, often chronic, gets worse with stress. Depression is common alongside it.
Okay. What about phobias? We mentioned those a bit.
Right, the intense, irrational fear of a specific object or situation. Spiders, heights, enclosed spaces, needles. The fear is totally out of proportion to any actual danger.
And exposure causes panic.
Yep, panic symptoms hit. The sources list types like animal, natural environment, blood injection injuries, situational. The person often recognizes the fear as excessive, but feels powerless. Adult phobias usually need therapy, like desensitization. They give those specific names like acrophobia, claustrophobia. Good terms to know for your exam.
And agoraphobia is a specific type of phobia.
It's related but distinct. It's the fear of being in places or situations where escape might be difficult, or where help might not be available if you have panic symptoms or feel incapacitated.
So it's not just fear of crowds, it's fear of being trapped in a crowd if panic hits.
Precisely. Fear of being vulnerable. They list common situations: public transport, open spaces, enclosed places, lines, crowds, being outside alone. People avoid these places or endure them with intense dread, often needing a companion. It's persistent, causes major distress, and the core fear is about escape and lack of help.
Different from social anxiety, then.
Yes. Social anxiety disorder, SAD, or social phobia, is about fear of negative evaluation. Fear of doing something embarrassing or being judged harshly by others.
Like public speaking or eating in front of people.
Exactly. Fear of scrutiny, conversations, meeting new people, being observed, performing, even using a public restroom. Exposure leads to panic symptoms. It really impacts quality of life because it hits social interaction directly. Often starts in adolescence, can be lifelong. CBT and SSRIs like Zoloft are highlighted.
Got it. The sources also quickly mention PTSD linked to trauma, re-experiencing, avoidance, numbing, hyperarousal.
Right. And two other important categories: anxiety caused by medical conditions and anxiety caused by substances.
So, anxiety attributable to another medical condition, like thyroid problems or COPD.
Yep, or diabetes, B12 deficiency, even things like concussion or dehydration. The key there is you treat the underlying medical issue first.
And substance-induced anxiety disorder, from drugs or alcohol.
Exactly. During intoxication or withdrawal, alcohol, benzos, stimulants, caffeine, cannabis, the anxiety is more severe than you'd typically expect and needs specific attention, often seen in what's called dual diagnosis.
Okay, that covers a lot of ground on anxiety itself. Now, what about the related disorders, the OCD spectrum?
Right. Starting with obsessive-compulsive disorder, OCD itself, defined by obsessions, compulsions, or both. They cause major distress or impairment. The person usually gets that the behavior is excessive, but feels compelled to do it for relief.
So obsessions are the thoughts.
Persistent, intrusive, unwanted thoughts, images, or impulses. They cause anxiety or distress, feel irrational, but you can't just ignore them or reason them away. Contamination fears, excessive doubting, needing things just right, fears of harm.
And compulsions are the actions.
Repetitive behaviors or mental acts done in response to the obsession aimed at reducing the anxiety or preventing some dreaded event. Checking, washing, counting, ordering, repeating words. They're often not realistically connected to the fear, or they're clearly excessive. OCD hits men and women equally.
Okay. What about body dysmorphic disorder, BDD?
This is a preoccupation with a perceived flaw in appearance. Either the flaw is imagined, or if it's real, the person's concern is wildly excessive.
Like focusing on tiny wrinkles or the shape of their nose.
Exactly. Often face or head, but can be any body part. It causes significant anxiety and impairment. They usually know the belief is exaggerated, which differentiates it from delusion, but it's still very consuming. High rates of depression, OCD. They might seek lots of cosmetic procedures. SSRIs, often at higher doses, are the main treatment mentioned.
Then hair pulling disorder, trichotillomania.
Recurrent pulling out of one's own hair, leading to hair loss. There's often this increasing tension beforehand and then relief or gratification after pulling. Scalp, eyebrows, eyelashes are common sights.
Why is it in the OCD spectrum?
Because the pulling behavior is seen as a way to reduce anxiety or tension, similar to a compulsion. Treatment is tricky. SSRIs show moderate results, and N-acetylcysteine is mentioned. Habit reversal training is a key therapy.
And hoarding disorder.
Persistent difficulty getting rid of possessions, regardless of their value. Things pile up, cluttering living spaces, sometimes making them unsafe or unusable. It often involves excessive acquiring, too.
Does it get worse over time?
Yes, the sources say symptoms often become more severe with age. It can co-occur with anxiety, depression, personality issues. Treatment is really challenging because insight is often limited and relapse is common. CBT is the main approach.
Okay, quite a range of related disorders there. Now, briefly, the sources touch on crisis and disaster. How are they relevant here?
Well, they're related to extreme stress, but distinct from anxiety disorders. A crisis is a profound disruption of someone's usual psychological balance. It's acute, sudden, triggered by an identifiable event, time-limited. Importantly, it's not necessarily pathology. It's when normal coping fails. The potential for growth exists. It's different from ongoing panic disorder or the scale of a disaster.
And a disaster is?
Bigger scale. Overwhelms community resources, threatens safety. Think hurricanes, Earthquakes, large accidents. It shares stressors with a crisis, but impacts a whole community.
And the nurse's role changes in these situations.
Absolutely. Disaster nursing involves preparedness, response, recovery. On the ground, it means things like triage, deciding who needs care most urgently, managing resources. But also, psychological first aid, recognizing distress is normal, providing support. Nurses face tough ethical calls and need to understand how different groups, like kids, might react.
Helping people manage anxiety, express feelings safely.
Exactly. Promoting coping and community resilience.
Okay, really important distinctions. Now, let's really zero in on the application for you, the nursing process as laid out in the sources. This is critical for your exam.
Absolutely vital. It starts, of course, with assessment. Gathering data, yes, but also analyzing it, recognizing cues, like seeing excessive hand washing and thinking possible OCD. Using your knowledge of these disorders.
They mention assessment scales.
Yes, like the Hamilton Anxiety Rating Scale, HAMA. It helps quantify the severity, mild, moderate, severe, based on symptoms. It gives you an objective measure.
Okay, after assessment comes diagnosis and outcome identification.
Right. Using standardized nursing diagnoses, the sources list NANDA-I diagnoses relevant here. Things like panic, anxiety, powerlessness, fear for 8 phobias, ineffective coping for OCD, disturbed body image, BDD, ineffective impulse control, trichotillomania. These give structure to your care plan.
And the outcomes are the goals, what we want the patient to achieve.
Exactly. How do we measure success? Outcomes need to be realistic and patient-centered. Examples. Can the patient recognize their anxiety escalating before panic hits? Can they use coping skills? Can they function near their phobic object? Can they reduce rituals? Verbalize a realistic body image? Demonstrate alternative behaviors to hair pulling?
Makes sense. Then planning and implementation, doing the interventions.
This is the action part. The sources give great examples tied to specific diagnoses. For panic anxiety, the immediate priority is safety and reducing anxiety.
Like staying with the patient, using a calm voice, simple words.
Exactly. They can't process complex info during panic. Reducing stimuli helps. Cautious use of a paper bag for hyperventilation, if appropriate medically. Administering meds is ordered, and only exploring the reasons behind the panic after the acute phase passes. Teaching coping skills for prevention is huge, deep breathing, relaxation exercise.
For fear phobias, it's about understanding their perception, reality testing, empowering them.
Yes, and often referral for specific therapies like systematic desensitization. That's the gradual exposure while relaxed, working up a fear hierarchy. Or implosion flooding, which is intense exposure without relaxation until the anxiety drops. Needs careful handling.
For ineffective coping, OCD, you don't just stop the rituals immediately, right?
Yeah, that could cause panic. Initially, you allow time for rituals while building trust and exploring triggers. Provide structure. Then, gradually limit ritual time while reinforcing alternative, adaptive coping strategies. Teaching thought stopping and relaxation helps them interrupt the cycle.
For disturbed body image, BDD, you have to acknowledge their perception first.
Yes, it's real to them. Then gently help them see the distortion, verbalize fears, find coping skills. Focus on activities that build self-worth away from appearance. Support groups can be helpful.
And for ineffective impulse control, trichotillomania, habit reversal training, HRT, is key.
Very much so. That involves awareness training, recognizing the urge, competing response training, doing something incompatible like fist clenching, and social support. Also, stress management and reinforcing activities to keep hands busy. Importantly, offering support through setbacks. Change takes time.
Patient and family education seems crucial across the board.
Absolutely. Teaching about the illness itself, symptom management, medication side effects, timing, when to call stress management techniques.
Like all those complementary therapies listed, relaxation, yoga, music, pet therapy.
Yes, providing non-drug tools is vital, and connecting them with support services, hotlines, groups, therapy. Empowering the patient to recognize triggers, use skills, and manage their condition.
Finally, evaluation, checking if the plan worked.
Exactly. Reassessing against those outcome criteria we set. Did the patient meet the goals? Can they manage anxiety better? Are rituals or pulling reduced? Do they have a better self-perception? It closes the loop of the nursing process.
Great overview of the nursing process application. Let's quickly elaborate on some of the treatment modalities mentioned.
Okay. Individual psychotherapy can be supportive or insight-oriented, exploring deeper conflicts. Psychoeducation is often part of it.
Cognitive behavior therapy, CBT, sounds like a big one.
It is. Focuses on identifying and changing those distorted thought patterns that fuel anxiety. It's usually structured, collaborative, relatively brief, and involves homework, practicing new ways of thinking and behaving.
And behavior therapy includes those techniques for phobias and OCD.
Right. Systematic desensitization, implosion flooding, habit reversal training, directly targeting the maladaptive behaviors.
Plus the complementary therapies we have mentioned, yoga, massage, acupuncture, non-drug approaches.
Exactly. Important options, especially given potential issues with some medications.
Okay, let's talk psychopharmacology, the medications.
Right, the anti-anxiety agents or anxiolytics. Used for anxiety disorders, withdrawal, sometimes muscle spasms or seizures. The sources stress that long-term use, 4 months, isn't well studied for many, and they're often adjuncts due to dependence risk, especially with
Benzodiazepines, like Xanax, Ativan, Klonopin.
Exactly. They work by boosting GABA, that calming neurotransmitter. But the big risks are tolerance, needing more for the same effect, dependence, addiction, and serious withdrawal. If stopped abruptly, you must paper them.
Side effects nurses need to watch for?
Sedation, dizziness, poor coordination, confusion. They potentiate other CNS depressants, especially alcohol. Very dangerous combo. Caution is needed in the elderly due to falls and confusion. Alprazolam, lorazepam, clonazepam are noted as effective for panic.
What about non-benzodiazepines, like bispirone?
Bispirone is important because it doesn't carry that dependence risk. It works on serotonin receptors. The catch is the delayed onset takes 10-14 days to work, so it's not for immediate relief or PRN use. Good for longer-term management. Hydroxyzine, Visceral, is another non-benzo anxiolytic mentioned.
And meds primarily for sleep.
Yeah. The sources mention the Z-hypnotics like Zolpidem, Ambien, and the melatonin agonist Rameltein Roserum for sleep issues that often accompany anxiety.
Okay, then antidepressants used as anxiolytics. This seems common.
Very. SSRIs, selective serotonin reuptake inhibitors, are often first line. Prozac, Zoloft, Paxil, Lexapro. They increase serotonin. Side effects can include nausea, headache, sexual dysfunction. Several are FDA approved for specific anxiety disorders.
SNRIs too. Effexor, Cymbalta.
Yes, serotonin norepinephrine reuptake inhibitors. Also commonly used, some FDA approved for GAD. Tricyclics, like clomipramine and Afrinol, are effective especially for OCD, but often have more side effects.
Even antihypertensives, blood pressure meds.
Yep. Beta blockers like propranolol can help control the physical symptoms, racing heart, tremors. Really useful for situational anxiety like performance or test anxiety. Not usually first line for GAD or panic disorder, though. Alpha-2 agonists like clonidine can help in withdrawal states.
And anticonvulsants.
Some, like pregabalin Lyrica, show benefit, but also carry some risk. Others are being explored.
The sources also mention novel treatments briefly.
Yeah, just acknowledging ongoing research into things like ketamine, cannabinoids, with caveats about THC versus CBD, even psychedelics in controlled settings. It highlights that about a third of people don't respond well to current treatments, so new options are needed.
Okay, could you quickly summarize the main meds mentioned for the specific disorders? Just a quick recap for studying.
Sure. For panic and GAD, benzos like alprazolam, lorazepam, buspirone, tricyclics, definitely SSRIs and SNRIs, several FDA approved, sometimes antihypertensives. For phobias, often therapy is key. Meds might be SSRIs, especially for SAD, like paroxetine, sertraline, maybe benzos for SAD, beta blockers, propranolol for performance anxiety. For OCD, SSRIs are primary, fluoxetine, sertraline, etc., FDA approved, and the tricyclic clomipramine, also FDA approved. Often need higher doses than for depression. For body dysmorphic disorder, SSRIs, again, often higher doses. Clomipramine and fluoxetine were specifically named in one source. For trichotillomania, no single standout med. SSRIs show moderate results, and acetylcysteine and a few older meds like chlorpromazine or amitriptyline were also listed as possibilities in one source.
Yeah.
HRT is the main non-drug approach.
Wow. Okay. That is a genuinely deep dive into this material. Really comprehensive.
It is a lot, but hopefully breaking it down like this gives you, the UTMB students, a really solid handle on the key information from these sources for your exam.
Absolutely. We've gone from the basic definitions, stress versus anxiety versus fear, through the complex causes, the different ways these disorders show up, the nuances of crisis and disaster, and really dug into that crucial nursing process: assessment, diagnosis, planning, intervention, education, evaluation.
And we cover the treatments and therapies like CBT and desensitization, the complementary approaches, and a detailed look at the medications, thinking about why they work and what nurses need to watch for.
Remember, as you're studying, the real value comes when you connect this knowledge to potential patient scenarios. How would you recognize these cues? What outcomes would you prioritize? How would you tailor those interventions?
And maybe a final thought to leave you with:
We've talked so much about that complex mix of biology, psychology, and environment behind these disorders. So, thinking about the nursing process again, what specific nursing actions, assessment strategies, intervention choices, educational approaches do you think are most vital for achieving that truly holistic, patient-centered care, moving beyond just treating isolated symptoms to helping the whole person manage their anxiety? Something to really mull over as you prepare.